So I'm Pratik Patel. I'm a spine surgeon from Vadodara, Gujarat. So I'm a proud member of Endospine 360 family. I did my fellowship under Dr. Prasad in 2022. Then my journey of endoscopic surgery has been starting from the transforaminal, then interlaminar, and then para PSLD now. So today my topic is pitfall and limitation of interlaminar endoscopic surgery. That means common problem of selection of cases and what are the complications that may go wrong during the surgery or after the surgery. So we know that interlaminar endoscopy is a minimally invasive technique that accesses the spine through the interlaminar window, commonly used for the discectomies, decompression and foraminal stenosis. We have been gone through this evolution, nomenclature, and what are the different generation of the scope that is available in the market. So when we are dealing with the scope, we should be know that what are the size, different diameters, and what are the materials, less angle, water pressure, design of channel, and durability and instrument, and what are the different generation of scope. So starting with the topic that is pitfall and limitations. Those are different limitations when we divide into the anatomical consideration. Second is intraoperative pitfalls. Third is pathology specific limitation, equipment related issues, patient related problems, learning curve, and post-operative complications. So starting with the anatomical consideration, first is the interlaminar window. So as we see in the lower lumbar spine, the interlaminar window is quite wide compared to upper lumbar spine. So it requires more bony work at upper lumbar spine. Second, as we see in this image, that lower lumbar spine, the interlaminar window at the same level at the disc level. As we go to the upper lumbar spine, the interlaminar window is quite below to the disc level. So it requires more bony work, specifically in L1, L2, and L2, 3, 4. Another is facet orientation and facet angle. So as we go to the upper lumbar spine, the facets are more vertically oriented, like F1 and F2 facets, and the lower lumbar spine is like more horizontally oriented facets. So we should know that minimum 20-degree angle should be there between the facet angle and the scope to prevent the instability. We should keep in mind that what is the facet tropism and spinous process tilting. So as we see in this case, on the lower MRI image on the right side, the left facet is more horizontally oriented compared to the vertical facet on the left side. So if you are selecting this approach, it's better to go from the left side to prevent the instability. Another is facet tilting and the cases of Dijon scoliosis. So if we see the Dijon scoliosis, the maximum of time, like the spinous process is tilted on the concave side. So if you are selecting this approach, if we are going from the left side, it is always better from the convexity side to access the canal properly and prevent the instability. Another is facet overhang. Like if you are using a stenoscope which is 10 mm outer diameter, it is very difficult to dock specifically in such kind of facet. For this 8.4 scope with 5.7 inner diameter is better. Another is high iliac crest, specifically for alpha S1 level. It's more problematic for the transforaminal surgery than interlaminar surgery. Now second topic is the intraoperative technical pitfalls. So first complication is dural tear. The reported incidence is 0.5 to 3%. These are mainly in the revision surgeries, calcified disc herniation, and elderly patients with fragile dura. The common mode of injury is mechanical injury, thermal injury, or traction injury. So maximally time the small tear can be managed with dural preservation with conservative management, but large tear may require sometimes to convert it to the open or dural repair and endoscopic repair. We know it's very difficult. The techniques are coming up in the market, but it's still evolving. Another is neural injury. The reported incidence is 0.2 to 1.5%. The common mode is mechanical injury, thermal injury, traction injury, or delayed edema. The contributing factors are the poor visualization, inadequate decompression can lead to the delayed injury. The anatomical challenges like calcified, far migrated disc. The preventive strategy is adequate hemostasis, minimum instrument trafficking, use of neuromonitoring, and meticulous MRI and CT scan review. Another is bleeding. It is mainly because of the poor visibility, lead to poor visibility, prolonged operative time, incomplete decompression, iatrogenic nerve injury. The more problematic in interlaminar than transforaminal. The common source of bleeding is muscle, bone, arterial, and venous. It is more common in the revision surgery, patient on blood thinners, increased intra-abdominal pressure, improper positioning, patient on the Wilson frame. The preventive strategy is reverse Standenberg position, use a diamond burr, good use of RF, and controlled irrigation at 50 to 70 mm of Hg. Another problem is inadequate decompression. The reported incidence is 3 to 10%, mainly because of limited visualization, inadequate bone drilling, residual fragment and scar and the adhesions. The risk factor are inadequate familiarity with the anatomy, far migrated calcified disc, severe stenosis, listhetic case or revision surgery. So it's always better to do a systemic decompression starting with the center, go to the shoulder, then axial and then annular base. Always preoperative planning, FABDIS algorithm, endoscopic mobility, good pulsatile movement of decompression is very important. Another is intraoperative technical pitfalls related to fluid pressure. So we know that is proper fluid flow will give a continuous visualization by clearing the debris. It is act as a coolant for the burr, RF probe, shaver, create a tamponade effect for the minor bleeding and maintain the optical cavity. The standard working pressure is 30 to 60 mmHg. It may go up to 80 for a brief period of time to control the active bleeding, but not for a long time. So controlled via the gravity-fed system, manual pump and automated irrigation system. So if we elevate the pressure, it gives a better visualization and bleeding control, but it risks the neural injury, dural sac flattering, increase the intracranial pressure and the retroperitoneal fluid extravasation. And the dural tear plus high pressure is very dangerous to increase the CSF pressure. So we should know this Bernoulli's principle. It's basic physics that intracanal pressure should be between 30 to 60 mm of Hg. The fast moving fluid is generate a low pressure. So if you are using a 10 mm scope which has a 7 mm working canal, and if you are comparing with the 5.7 mm working canal, so 7 mm canal, the working canal is bigger, so the fluid inside pressure is less. So if you are reducing the working canal, this increase the pressure inside the cavity. Another thing is pathology related problems, like these are the cases we should be aware in initial learning curve that we should not touch these cases. Like first is migrated disc. In my practice, I find difficult to handle the far inferior migrated disc herniation rather than superior migrated. So if initial for 30 cases, better to do a near migrated disc herniation rather than far up or down migrated disc herniation. Another is calcified disc herniation. These are very difficult to handle, specifically endoscopically. Another is far out syndrome, specifically para-PSLD. Another is multi-level decompression. It is also very difficult to do 2 to 3 level on initial learning curve. Another is revision surgery or adjacent level diseases. Another is equipment related constraints. So as we are new to the scope system, so we should aware the different diameter of the scope that is available in the market. As we know that narrow channel can compromise the suction cavity during the bleeding. Another is visual limitations. Lens fogging, bleeding, turbidity can increase the impaired endoscopic vision. Endoscopic optics often lack stereoscopic depth cues and spatial judgment may be misleading. Another is instrument failures, like risk of shaft bending and breakage during the bony decompression, particularly when the torque exceeds the design strength of the endoscopic tool. This specifically happens when you drilling the lamina. Regularly on initial learning curve, I used to break like 2 to 3 in every my 5 case I used to break burr because of the if exceed the torque, it's very difficult that when you are not doing properly the movement of the scope with the burr, and if you are like bending a burr during the without movement of the scope, it lead to the breakage at the shaft. So this is very important. Another is we should know that different company and the size of the scope that is available in the market. The design of the endoscope and the angle, which has already been discussed. If you are comparing with the microscope, we are in microscope we are working outside the cavity. The uniportal endoscopic system, we are working inside the cavity. Our hands are cuffed, but the handling of the instrument is better because we are working with both the hand. For biportalscopy, the scope is one hand and instrument in another hand. So chances of instrument slippage is more compared to the uniportalscopy. So this is the vision, like if you are standing on the ipsilateral side, like 6 o'clock position, if the 15-degree angle scope we are using, so we can see of that opposite side 15 degree. When we stand on the ipsilateral side, the optics on our side and the working canal is on the 12 o'clock slide. If we rotate the scope by 180 degree, the optics on the opposite side and the working canal is on our side. Another is patient-related limitations. Like first is obesity. Increased soft tissue death can alter the trajectory and limit instrument mobility. High torque required for the sheath insertion increase the strain on the surgeon and the equipments. Another is deformity and instability case. Like Dijon scoli and Dijon listhesis often require segmental stabilization, which is beyond the scope of purely endoscopic decompression. An interlaminar approach may not allow complete multilevel decompression in deformity cases. Another is previous surgery. The scar tissue and altered anatomy, post-laminectomy and discectomy increase the risk of dural adhesion and orientation problem. So it is always better to avoid a pure interlaminar endoscopy in gross instability, high-grade listhetic and kyphoscoliotic cases. Another is learning related issues like steep learning curve. Unlike microscopic surgery, endoscopic decompression require mastering the rotatory technique, single-handed dissection and the fluid mediated visualization. So another is error in targeting, like intraoperative navigation or use of neuronavigation tool may require for beginners to avoid the disorientation. The high early conversion rate, like studies suggest that 10 to 15% of cases of interlaminar endoscopy may require conversion to open due to the poor visibility and complications, specifically in initial learning curves. Another is post-operative complication like persistent radiculopathy, maybe mainly due to the incomplete decompression and unrecognized extraforaminal component. The second is recurrent disc herniation. It is mainly because of the large annular defect, poor annular healing and the residual fragment retention. Early recurrence typically within the 6 months, often necessitating the reoperation. Another is infective and fluid complications. It is breach in the irrigation circuit. Sterility may lead to the epidural abscess. Epidural pressure elevation like transient foot drop or quad equina symptoms may occur because of the fluid pressure. So if we compare this transforaminal interlaminar technique with transforaminal surgery, the interlaminar is more better for the L5S1 and L4-5 compared to the high lumbar spine. It is better to access the central pathology. The far lateral lesion is better handled with transforaminal than interlaminar. The facet violation is moderate in interlaminar compared to transforaminal. The bleeding risk is higher in interlaminar and the learning curve is steep. So if I conclude with interlaminar endoscopy limitation, the interlaminar endoscopy is powerful tool, specifically in MIS armamentarium, but must be used judiciously. Thorough preoperative planning, mastering the endoscopic anatomy and understanding the limitation are essential for the safe and effective outcome. The surgeon humility and case selection, continuous learning are the cornerstone of minimizing the complication and maximizing patient output. So endoscopy is a boon, but right concept matters the most. A well executed surgery is poorly indicated case will not give a good results. Respect the learning curve, progress slowly, and most importantly, understand when to stop. The case selection and execution is the most important here in endoscopic spine surgery than open surgery because margin of error is less. Your zeal to master and quickly cross the learning curve of endoscopic spine surgery should never come at the cost of patient safety and compromise surgical outcome. Thank you.